Hi, my name is Taylor, and this week we'll be doing a snippet video on the use of calcium channel blockers for the treatment of preterm labor. The intended audience for this module is for new inpatient obstetric nurses as part of the orientation process, and the student learning objectives include that the student will be able to discuss and educate with patients why calcium channel blockers are used in preterm labor, and that students will be able to state the goal of calcium channel blocker therapy in preterm labor. So let's first define preterm labor. It is labor that occurs between 20 and 37 weeks gestation. Labor itself is defined as cervical dilation or cervical effacement along with uterine contractions. There are many treatment modalities for preterm labor, but all tocolytic therapies aim to prolong the delivery. This allows for stabilization of the patient, transfer to a higher level facility if needed, and for steroids to be administered. Currently, there are no tocolytic therapies that are proven to stop preterm labor, but like I said, all the modalities aim to prolong the delivery. The specific calcium channel blocker that we will be discussing is nifedipine, or known as Procardia. The mode of action is that it blocks calcium from entering smooth muscle and cardiac cells. This causes vasodilation and decreased muscle tone. Normally, an influx of calcium is needed in order for the muscles to contract. Calcium channel blockers are often used in hypertension and angina patients due to the same vasodilation effects. With regards to preterm labor, it is important to understand that the uterus itself is a smooth muscle, and therefore the frequency and intensity of any contractions that a patient with preterm labor may be experiencing are decreased when the muscle, the uterus, is relaxed through the administration of calcium channel blockers. This drug is often used due to its high level of safety. The side effects are very low risk, especially compared to other tocolytic therapies. This medication is readily available and is very cost effective. The expected outcomes for this medication are to delay delivery again for at least 24 to 48 hours to allow for transfer and administration of steroids. So we'll compare this calcium channel blocker nifedipine to an NSAID Indocin. As stated earlier, nifedipine has very low side effects. Possible side effects, though, are hypotension and potential changes in the placental uterine blood flow. This drug is metabolized by the liver. The other medication that we'll compare it to is Indocin or indomethacin, which is an NSAID, so it's a prostaglandin inhibitor. Normally, prostaglandins contribute to uterine contractions. This drug is also readily available and is cost effective. However, the side effects are a little more severe, or can be more severe, because it can cause premature closure of the fetal ductus arteriosus. This drug is specifically only used as a tocolytic before 32 weeks gestation and is also metabolized by the liver. So the best approach for any clinician is to use an individualized approach and always weigh benefits and risks to determine which tocolytic therapy will be best for your patient. I hope you have learned a little bit more about the use of calcium channel blockers and the use of preterm labor. Again, my name is Taylor. Thank you.